Good morning, everyone. We are going to we know in distal gastric carcinoma and distal gastrectomy. Last week, we performed a case of Mr. Thakuri, 77 years male, married from Bharatpur, Nepal, who presented to us with a chief complaint of diffuse abdominal pain for about 1 month and also gives a history of black tarry stool 2 to 3 episodes in the same last 1 month. He did not have any comorbidities. His ECOG score was 1. His general condition was fair looking, but pallor was present. No icterus, no lymphadenopathy. Obviously, lymphadenopathy was present. And on core abdominal examination, abdomen was soft, non-tender, and no obvious mass was felt. And after that, he underwent endoscopy. We showed a single ulcerated large lesion over the antrum, and from which biopsy was taken. And biopsy showed the presence of adenocarcinoma in the ulcerated proliferative lesion. And this is the after that we perform the CT, and this is the CT scan. So diagram part here. Here we can see this is the distended abdomen, and gradually while going down, this is the antral growth, which is evident here. And after that, the duodenum is patterned, and no significant lymph node was present while forming this CT scan. And after that, with the finding of ulcerative proliferative lesion in the antrum and presence of mass in the CT, this is the same CT where we will appreciate the growth. We decided to go for distal gastrectomy, and his pre-op investigation were done. And during the pre-op investigation, we found he had only the hemoglobin level of 7.6. Thus, for preparation, we transfused 3 pint of blood, and after that, the hemoglobin reached 11. And then thereafter, we performed the distal gastrectomy with a diagnosis of CS from distal. Distal subtotal gastrectomy with D2 lymphadenectomy plus level 14 lymph node were dissected. Intraoperatively, we found a firm mass about 3 to 3 centimeter in the anterior wall of antrum, which was involving all layers of gastric wall, involving the serosa, and there was also a small thickening over the lesser curvature. And during the intraoperative, we encountered few whitish subcentimetric deposit around the right gastroenteric vessels and the superior mesenteric vein, which we removed, and there were no other deposits or ascites or other visceral organ metastasis were seen. And this is the specimen that we retrieved. Here we can see the small thickening over the lesser curvature, and this is the mass that was present over the antrum, and it has also invaded the serosal layer. And using intraoperative, the whitish deposit over the node 6 and 14 is not evident over it, but we removed it separately and sent for histopathological.
Prem Singh Thakuri, case of distal stomach CA, and this is the counterpart, and this is the head part, and this is the leg part, and this is the surgical field after the excision of the tumor. Here we can see superior mesenteric vein, and this is the pancreas. We have cleared the level 14 node, and this is the duodenal stump, and this we have cleared the level 8, 7 nodes, and this is the common hepatic artery, this is the splenic artery, and we have ligated the left gastric artery, and this is the celiac trunk, and here is the aorta. We have properly cleared all the lymph nodes, and here we have performed the gastrojejunostomy, and we will be performing the bronze anastomosis.
And the role of level 14 node in distal gastrectomy. According to the Global Observatory, gastric carcinoma is ranked 5th most common cancer worldwide and also the 5th leading cause of cancer-related death. And it has highest incident rate in our region, that is East Asian countries like Japan and Korea. And after that, in some South American countries. And although many advances has been done, the chemotherapy, targeted therapy, and the radical surgery is till now the most effective treatment strategy. And lymph node invasion is the primary prognostic factor in the gastric carcinoma. And this is the short table with the recent gastric carcinoma Japanese classification and given the treatment strategy for lesion, T1 lesion, and with no nodes and with no ulcerative lesion and less than 2 centimeter differentiated lesion, we go for endoscopic resection. And with T1 lesion, but size more than 1.5 centimeter, we go for D1 gastrectomy. Or if invasion or other nodes are present, then D1 dissection is done. And for any lesion, any N1, N plus lesion that is size T1 or more than T1, T2, T3, T4, we go for standard D2 dissection and gastrectomy. And for T4B lesion or presence of any metastasis, combined resection with the embedded organ is done. And after the surgery for stage 1 pathological lesion, we go for observation. And for stage 2 and 3, except for T1 lesion and T3 P0 lesion, adjuvant chemotherapy is given for and for any stage 4 disease, chemotherapy and with the supportive care is the management that we are following in our center. And this is the various lymph node level as per the Japanese classification, which is involved or resected during the gastrectomy. And we will be more focusing today on level 14B, that is lymph node along the superior mesenteric vein over here, and its significance in the distal gastrectomy. And according to the Japanese classification, distal gastrectomy they involved as per the D1, D1 plus, and D2. In D0, lymphadenectomy less than D1 is done, that is which involve D1 involves level 1, 3, 4 SV, 4D, 5 and 6 lymph nodes. And for the D1 plus, 8A and 9 are involved. And for D2, D1 plus 8A, 9, 11P and 12A lymph nodes are dissected during the procedure. And D2 lymphadenectomy and the role of adjacent level 14B. Initially, in the gastric classification of gastric carcinoma in the second edition, that is the 13th edition, they included the 14B lymph node in the as a part of D2 gastrectomy, as they involved the 14B as a regional lymph node, but with third and the fourth version, with the latest version 4, they have removed this routine removal of the 14B lymph node, since there was no strong evidence of the 14B lymph node involvement, and also there was more complication rate. That's why they removed the routine removal of 14B from D2 gastrectomy. But in some cases, like presence of metastasis to level 6 nodes, and in the cases of suspected ergo to duodenum, they still involve the level 14B node. And any dissection, lymphadenectomy beyond D2 is now classified as non-standard gastrectomy in case of the stomach. And this is the different treatment or surgical strategy and lymphadenectomy during the D2 gastrectomy. And only the Japanese classification has involved the level 14B during the D plus lymphadenectomy and gastrectomy, and other have not included the level 14B. And frequency of level 14B metastasis, there are many studies, and I have included 3 of them, and which ranges from presence of 4.3 to 18.5% in the cases. In one study, these are mostly done in Japanese population, these all studies, and they have found that as the TNM staging gradually increases and also the nodal involvement increases, the metastasis to level 14B has prominently been seen. And also those with involvement in later stages like stage B, stage 3, 4, the presence of 14B metastasis has been seen in most cases. And For the classification of the to be seen that it is a metastatic node, intraoperatively we can feel this lymph node and also see the appearance. And usually the intraoperative, the lesion is seen as larger than the normal uh, lymph nodes, and it is firm and sometimes even feel as hard to stony. And these are less mobile and often fixed to the surroundings, and they are more rounded compared to the benign oval or the elliptical shape of the lymph node. And the length to short axis ratio is less than 2. And in the imaging, either ultrasonography or CT scan, these lymph node, malignant lymph nodes are seen more large and more rounded or irregular in shape. And there is presence of heterogeneous internal structure with usually the central necrosis and indistinct margin and benign sharp. As compared to the benign sharp margin, the margins are indistinct, and also in some cases we can see the loss of tissue plane around the lymph nodes. And in our case, we performed level 14V dissection because as we were performing the surgery, we could see there was a level 6 node was slightly enlarged and rounded in shape, and also there was small subcentimetric deposit around them, and also there was presence of subcentimetric deposit around the level 14V node. That's why we dissected the both level 6 and level 14 nodes. And in our center, we sometimes don't get the privilege of the frozen section. That's why on the basis of the intraoperative finding, we decide whether to go for level 14V dissection or not. And also in our case, there was involvement of the serosa, which is also one factor for the removal of the 14V nodes. And this one article, we showed the current status of the lymph node dissection in gastric cancer. And as per this article, they have suggested that in D2 plus dissection, superior mesenteric vein lymph node level 14, dissection is usually recommended if there is metastasis in the level 6 node if suspected. And there is also another article which supports the removal of 14V lymph node in D2 gastrectomy in advanced distal gastric carcinoma, which has suggested that there is improved overall survival of the patient with a clinical stage 3 and 4 advanced carcinoma disease, which has involved the middle and the lower third of the stomach. And there is another article which also supports that the superior mesenteric vein 14 lymph node in subtotal gastrectomy carcinoma can be done, especially in the cases which has involved the level 6 node. And also the in this article they have pointed that if there is enlargement of involvement of level 11P node, then also it is better to remove the level 14V node for the better survival of the patient and clearing of the lymph nodes. In this is also Japanese article where the risk factors for the metastasis to level 14V lymph node and its prognostic value has been given, and this also supports that the status of 14V lymph node is also an independent prognostic factor for stage 3 disease, stomach carcinoma. And with the removal of the 14V lymph node, especially after the metastasis to 4D and the 6 lymph node, the removal of the 14V lymph node gives a better result in the overall 3-year survival. And there is also a supportive article that shows that there is positive impact and improve overall survival in with the removal of 14V lymph node in the highest stages of TNM, that is stage 3 and stage 3B and 3C. And they have compared the D2 and D2 plus radical dissection in advanced disease, and with the involvement of duodenum and the positive for lymph node, the removal of the 14V lymph node has shown correlate with higher survival rate and better result patients. And also this is one article which shows that if there is serosal involvement in the distal gastric carcinoma, then it is also an indication for the removal of the 14V lymph node during the procedure. And as a part conclusion, I will say that D2 lymphadenectomy plus 14V node may be beneficial for patients those who are suspected to harbor the metastasis to level 6 nodes and involvement of the serosa and distal carcinoma and T2 to T4 lesion, which are present in T1 plus any node levels. Thank you.
Antrum of the stomach. If it's located in the body of the stomach or located in the proximal 1/3 of the stomach, then it's the value of 14B is not there. It should be considered as stage 4 disease. Even right now, 14B dissect 14B even for the anterior tumor is not the distal lymph node. It is supposed to be the stage 4, but it has been shown in a particular group of the patient. We have got the level 6 means infrapyloric lymph node, which is quite useful. If the tumor is located in the antrum, it's quite usual the lymph node metastasis will go to the level 6 infrapyloric, but it's very resistant to that. On the top of that, if there is the serosal invasion, then the chances of having the level 6 is higher. So now how we will prove it? Either you have to send to the frozen section biopsy, or empirically, if you think on the ground of the clinical, the clear intraoperative findings, it looks oval, it looks malignant appearing. It looks round, it looks firm in consistency. The echo texture is different from the benign like fragile node. It looks malignant appearing. Then possibly in those cases, even without frozen, because in not all the centers we have got the frozen sections, so we can go further a step because there is the SMB which is lying just beneath the pancreatic neck. So you can mobilize that, you can clear out some of the lymph node that's called 14B lymph nodes. So the point is that what we want to do is we are moving back to the previous studies. The second edition of Japanese classification 14B was included in D2 dissection, which is not now. So why we want to move back into that historical ground? Because generally we have got the advanced stage of the gastric cancer. Gastric cancer is not so uncommon in Nepal, because in Nepal, if you see gastric cancer, it lies somewhere about 5th or 6th position among all the solid organs. Because it's not so uncommon. Advanced stage is very common. So, in the absence of frozen biopsy, we can run some of the pilot studies just to analyze how many of the anterior tumors have, what is the prevalence in the anterior tumors, locally advanced, which is obviously T3 or beyond. What is the chance that 14B will be positive? So in the same time, we can take out the level 6. It is the standard practice. So we want to see the correlation. This is the open floor. None of the studies have come from Nepal. I don't know any studies which have quoted that there is some evidence that what is the prevalence. I'm not talking about the survival advantage. What is the prevalence of 14B metastasis from Nepalese population? So we can come to some of the conclusions, maybe 20, 25 or 30 patients we can run a small study, pilot study, then we can have some conclusions. So that's why I think from now onwards, we have been rampantly doing this kind of dissection, but not recorded. So from now onwards, I would like that some of you, maybe Sachi has given this talk, so maybe if we have the gastric cancer surgery next time, then please routinely make it sure that 14B lymph node has been dissected for the anterior cancer and to see what is the rate of prevalence of metastasis in that group, whether it is associated with the serosal invasion or not, whether it is associated with lymph node metastasis of the lymph node 6 group or not. Okay? So this will be your for future study, if you can do that. Okay, sir, a question on
So त्यो हामीले यो ग्यास्ट्रिक ट्रङ्कलाई त्यो जिसिटिएसलाई ट्रेस गर्दै गएपछि त्यही वरिपरिको एसएमबीको वरिपरिको
एसएमबीदेखि जब हाम्रो बोर्डर के हुनुपर्छ भने एक्ज्याक्टली वेयर इज द 14B. So you don't need to do like the Whipple surgery, raise the pancreatic neck, go beyond. No. The GCTS will be arising just roughly at the region of the inferior border of the pancreas. So from that level beyond, till it will, the SMB will be dividing into the jejunal or ileal branches. Okay? Generally, it divides into the jejunal and ileal branches combined and make the SMB. So that will be the limit. The upper limit will be the inferior border of the pancreas or the beneath the pancreatic neck where the GCTS will trunk of level arrive, and from there to the bifurcation or trifurcation, whatever is the pattern of the assembly. So that should be the region of the assembly. With that part, we can dissect or see what's the rate.
In one article, it was also mentioned that involvement of 11p node also is a indication for the removal of the 14b.
11 पोजिटिभ छ भने मात्रै 14
6
6 हो क्या हैन
6
अनि 6 लाई फ्रोजन पठाएर हेर्ने छ अनि
So the standard practice, what Japanese recommend as of now, don't look for the serums in middle. So T2 plus according to them, the indication of 14B is antral location of the cancer 1 and level 6 lymph node metastasis 2. These are only two indications when both, not or, antral and level 6 lymph node invasion is the indication for 14. Not 11. ठीक है, it's okay.